Thank you, Professor Titial, for having me here and for the kind words of introduction. Current techniques of phacoemulsification require an intact capsulorhexis and capsular bag integrity. And most of the time, it happens that way. However, uh, in about 0.79 to 5.55% of the cases, literature shows that the rhexis runs off to the periphery. And in one study from Moorfields, which was published in the American Journal, this incidence was 1.5%, and the same study had a PCA incidence of 1.65%. So the question arises, like when we are confronted with a rhexis runoff, how do we proceed? Do you continue with phacoemulsification or you convert to a safer non-phaco technique? If we go ahead with phacoemulsification, do we modify our phaco techniques? Do we perform intercapsular phaco or we emulsify the nucleus at a different plane? And then finally, what kind of intraocular lens should be implanted when the rhexis has run away to the periphery? So these are the points that I'm going to discuss with you in my presentation today. The timing of the tear is quite important. The rhexis tear can happen in all these situations. And I have personally encountered a primary tear, particularly in intumescent cataracts where rhexis runs to the periphery. And I have also encountered secondary tears, particularly when the rhexis is small and the cornea is not very healthy. There has been visibility issues where I have torn the rhexis margin using the chopper or maybe with the phaco. It is also important to be familiar with the risk factors and be prepared, in terms of patient counseling as well as the OT, the vitrectomy unit, etc., whatever is required to manage this kind of cases. So I have had a lot of cases of intumescent cataracts over the years, and this is a case which I thought I'd like to highlight. And most of my rhexis tear has happened in intumescent cataracts. Here, of course, the rhexis could have been done differently, and my focus is not on how we could have avoided this runoff. So here it is tending to run to the periphery. I'm injecting OVD in the peripheral aspect. The needle was not giving me much control, so I used the Utrata forceps. I thought I had brought it back. Again, it had a tendency to go to the periphery. I used Hilon 5, mind you, Hilon 5, and it still runs to the periphery. So I decided to continue with the phacoemulsification in this case. And my focus, as I said, is not going to be on rhexis, but on how to perform phaco, how to manage the nucleus in this kind of situation. So I will be asking for a larger anterior capsular opening, because if the opening is small and when there's a rhexis discontinuity, the intraocular manipulations in the capsular bag may result in further run of the rhexis, incomplete rhexis to the periphery, and you can get a wraparound tear. So I'll try to get a rhexis about 5 capsular opening about 5 or 5.5 millimeters in size. It has to be done in multiple stages, and whatever the redundant capsular flaps, they have to be trimmed, because subsequently during phacoemulsification or during irrigation aspiration, if we have dog earing of the capsular flaps, redundant capsular flaps, they'll tend to come into the aspiration port. Sometimes you're not knowing about it, and then there could be disaster. So this is what I need to emphasize, that have a decent opening of the anterior capsule. Some surgeons would like to give a relaxing cut in the opposite meridian. For example, here the rhexis has run to the periphery. They would like to give a relaxing cut here. I'm not a very big fan of that strategy. So I would start off with phaco with a little high phaco power. I don't want any additional movement of the nucleus. So once I feel I'm deep enough into the substance of the nucleus, I'll start chopping it. While chopping it, make sure that the nucleus is elevated a little anteriorly. So during the lateral separation, there is no force that is transmitted to the capsular bed, to the area where the rhexis has run to the periphery. And vertical chopping is being performed using the Sinskey hook. You can use any hook, any chopper of your choice. Make sure that during the lateral separation, you are not working in the area where the rhexis has run to the periphery. So because the rhexis has not been intact, the nucleus has a tendency to prolapse into the anterior chamber. So that tendency has to be kept in the mind. And you need to use copious amount of a dispersive OVD, preferably Viscoat, to top up the anterior chamber to protect the corneal endothelium. Because many of these cases are just, as I just mentioned, it is impossible to get the small chunks of nucleus into the anterior chamber. The nucleus rotation again has to be performed very, very gently. Try to rotate the nucleus in such a manner after filling up the bag with capsule with OVD so that there's not much of stress in the area where the rhexis has gone to the periphery, and then continue with the phacoemulsification. You have to maintain the anterior chamber depth at all costs, because if there's a sudden shallowing of the anterior chamber, the rhexis tear may become a wraparound tear, and then a small or minor complication would become a very significant complication, which may even result in vitreous disturbance. So this particular discipline is very important. Use a dispersive OVD to protect the corneal endothelium, to protect the area where the rhexis may have run to the periphery. And once the nucleus has been removed, so the question arises, what kind of lens that you're going to use. So if you are using and planning for a single piece hydrophobic acrylic lens, I think one could still keep it in the capsular bag, because the unfolding happens very gently. But in this particular case, I am demonstrating the use of a 3-piece hydrophobic acrylic lens. So that goes into about 2.8 or 3 millimeter incision. Make sure that the leading haptic just grazes on the anterior surface of the capsule, of the anterior capsule. You may even deposit the leading haptic in the anterior chamber just in front of the iris if you're not sure if the pupil has come down, that you're really anterior to the anterior capsule. The trailing haptic, again, instead of being dialed in, is compressed and then just tucked under the iris. So you ensure that the long axis of the lens, the haptics, they're perpendicular to where the rhexis are run to the periphery. And in certain situations where a toric IOL is planned, it can still be kept in the capsular bag. And I have heard from colleagues that even if the rhexis runoff happens in the axis of the toric lens alignment, so that also has worked well in their hands. I have no personal experience. So this is the same patient followed up over a long period of time, and the patient has done extremely well. There has not been any IOL displacement. I had also obtained, I forgot to mention in the previous slide, posted a buttonholing of the optic. And this may be a little controversial, because if capsular fibrosis happens, the bag undergoes contracture because of a single discontinuity in the rhexis margin. There may be an asymmetric contracture, and the intraocular lens may be pushed, may get decentered. But it has not happened. Over 5 or 6 cases over the last decade or so, the lens has stayed well centered, the haptics in the sulcus and optic in the capsular band. So friends, must remember that rhexis is paramount for safe phaco, and further management options in compromised rhexis situations depends upon a lot of factors. For example, today, having been a phaco surgeon for almost 25 years now, more than that, now if I encountered a very hard cataract, a significant comorbidity in terms of shallow anterior chamber, unhealthy cornea, rhexis has gone off to the periphery on the nasal side, I would still not perhaps continue with phacoemulsification. I'll convert the case into a small incision cataract surgery situation. For a younger surgeon who is not familiar with SICS, it doesn't really, it's not really a shame to put a suture and refer the patient out to a more experienced surgeon, because a patient is not going to thank you for your boldness when you have a complication, when the visual outcome is suboptimal. Patient is going to thank you for good outcomes, even if it doesn't matter whether it has been referred to another senior surgeon who has done a good job. So it is a good idea to be familiar with manual small incision cataract surgery, or you could even convert to an extracapsular cataract extraction. Phaco can still be performed, as I have just discussed, if it is not an extremely hard cataract, preferably to do it endocapsularly. At times you can come up to the iris plane. The intraocular lens have to be chosen appropriately, and I have already discussed about it. So friends, good phaco is still possible in rhexis tear situation if you properly manage the intraocular environment and use a proper nucleus management strategy. Thank you very much for your kind attention.